Good evening, everyone. Today's class is going to be on optical aberrations, only the basic part of it. So here we see a picture of stars and the famous night sky drawn by Van Gogh. This is because each of us perceives stars differently because of the aberrations in our eyes. So even that is reflected in art that we create. Dr. Fritz Zernike won the Nobel Prize in Physics in 1953. He has done the most important work with relation to optical aberrations, although he won it for a different cause, which was the phase contrast microscope. So as we know that 2020 quantity is important, but more importantly nowadays with refractive surgery on the rise, even quality of vision is important. So what are the symptoms that a patient has if they have high aberrations, which we can see as glare, starbursts, ghosting, and halos? So a few basic points about what is a wavefront. So wavefront is basically a plane or a collection of points which are in phase. So if we see that these rays of light are all parallel, they are forming their each wavefront at each different point, and the wavefronts in turn are parallel. Once they go through a point, they start diverging, and hence the wavefronts are also diverging. The shape of the wavefront is dependent on where it is getting refracted from. So an ideal refracting surface, a parallel beam, that is a parallel wavefront on incidence onto an ideal lens causes a converging beam, which causes a spherical wavefront, and all of the points merge onto a single point, which is the focal point. So in an ideal wavefront, we have the object P over here. It forms an image on the retina, which is P dash, and the optical distance from P to P dash is the same for all rays. And the wavefront converging on the retina is always spherical, which is an ideal wavefront. In an aberrated wavefront, all the rays from object point P do not intersect at a common point P dash. That is, we have multiple points of foci on the retina, and the optical distance of P from P dash is not same for all the rays. Hence, we call this wavefront as an aberrated wavefront. So once we look at the aberrations, the image on the left shows aberrations as they are quantified on the pupillary plane and on the retinal plane on the right side, which is basically a function of the point spread function. In aberrations, usually the more we study aberrations, the more confused we get. So most of the times PGs don't study it at all to avoid any confusion. So in an ideal refracting surface, the light coming from infinity will refract at the surface, and the wavefront produced takes the shape of the refracting surface, and all the rays of light will focus on a single point. In an imperfect refracting surface, this does not happen. So root mean square is nothing but the measure of distortion or deviation of a wavefront from an ideal or a planar wavefront. It only quantifies the aberrations. It does not classify the aberrations. So the inference is that RMS only tells us if the eye is highly aberrated or mildly aberrated. Coming to Zernike polynomials, these are all the Zernike polynomials which Dr. Zernike has described. So I'll be discussing all of them in detail, one by one. So the top three, this 1, 2, and 3, all three of them are known as constant aberrations. The first one is a zero order aberration. The second two are the first order aberrations. The zero order and the first order aberrations are known as constant aberrations. The zero order aberrations are known as piston. In piston, it is analogous to a piston in the engine. As it goes up, the piston appears larger, and when it goes down, it appears smaller. It is not a qualitative aberration as it is just a variation in image size. So for example, when we see an eclipse, or when we are lucky enough to see the sun or the moon on the same night sky, we can see that roughly both of them are of the same size. However, we know that sun is many times larger than the moon, but still it appears to us as if they are of the same size. This is because the sun is equally proportionately farther away from us than the moon. So eventually it just appears to be as a discrepancy of the size. I mean, they appear same, whereas they are not. This is the logic behind piston. It is just a qualitative perception of the image. It is not a real aberration. So we do not consider it significant when studying for refractive surgery. The second one and the third one, I mean the first order aberrations, the left one is called as tip and the right one is called as tilt or horizontal tilt or vertical tilt. In this image, we can see that the poles or the columns or the structures appear at a slight slant. Whereas we know all of us know of this image very well. This is the Leaning Tower of Pisa, which is actually tilted. So again, in this image, we are just percepting that it is tilted, whereas it is straight. So tip and tilt are also constant aberrations, but they are qualitative aberrations and they are based more on the perception rather than reality. So we do not consider them as significant. Coming to lower order aberrations, which are important, we have horizontal and vertical astigmatism and defocus in the center, which is a positive defocus called as myopia, and negative, which is hyperopia. Also, I have to tell you that this image is taken on from pentacam. So even if somebody does not have an eye trace or an aberrometer, the pentacam also gives us aberration readings. So lower order aberrations are also the second order aberrations. Below that, whatever aberrations we see in the pyramid are all higher order aberrations, starting from the third order aberrations up to the number 27 order aberrations. Generally, for refractive surgery purposes, studies have shown that only three aberrations are clinically significant, which is coma, trefoil, and spherical aberration. The aberrations on the left half of the pyramid are vertical aberrations denoted in minus sign, and the aberrations on the right half of the pyramid are horizontal aberrations and are denoted in a positive sign. So quick recap, the zero order aberrations is piston, first order aberration is tip and tilt. All three of these are not clinically significant. The lower order aberrations, which are the second order aberrations, which are defocus and astigmatism, that is what we consider during surgery. And the rest of them are higher order aberrations. Of those, trefoil, coma, and spherical aberrations are the most important ones. So here in this image, we can see that each aberration is accompanied by a z value. This is called as a polynomial value. So each aberration has been defined a certain superscript and a subscript. So I'll try and decode that for you. The n in that stands for the radial function that is proportional to the order of polynomials, and m stands for continuous function that repeats itself every 2 pi radians, which makes no sense to us at all. So a simpler way of understanding it is that m denotes the number of affected meridians and n is the number of slopes along the affected meridian. I'm going to show you a few examples of how it really happens. So in this, we see that z minus 2 and 2. In this 2D image, we can see that there are two vertical primary meridians. So the m is 2, and across each meridian, we can see that there are two slopes. So the n is minus 2. Here is slope 1 and here is slope 2, and there are two vertical meridians. Since it is a vertical meridian, the sign is minus. Again, z minus 2 and 4. So we have two vertical meridians, which is minus 2, and four slopes along each meridian. This is the first slope, second, third, and fourth. In spherical aberration, there is no meridian, so it is denoted as 0. but there are two slopes, so we denote it as 2. So I hope this is clear. Moving on, lower order aberrations form 90% of the aberrations, which is defocus and astigmatism. Higher order aberrations form only 10% of those. Of the higher order aberrations, 98.2% of the higher order aberrations arise only from the anterior corneal surface. This is how spherical aberration looks. So if we consider the image as a point, if the eye is highly spherically aberrated, we are going to start seeing airy discs around it. This is an example of coma-like aberration in which there is a steep and a flat meridian, and there are two slopes along each meridian. Coma is usually seen in patients of keratoconus, patients with decentered ablations, decentered grafts, and tilted IOLs. So if this is a normal appearing point, a patient with high coma aberration is going to see a comet tail appearance. Coming to trefoil, in trefoil in nature we find a tree, and its leaves have a peculiar shape and a peculiar arrangement. So this is what it is derived from. So this is what it looks like. It looks roughly like a pyramid, similar to these leaves. So it is known as trefoil. So how do we actually measure aberrations, and what are the units that we use? We use point spread function, root mean square, and modulation transfer function. So in point spread function, the basic thing to note is that if it would have been a point and the image formed is a point, the deviation would have been very small. We can see that the image of a single point has been blurred at spread out over a large area. So the point appears not to be a point, but to be something of this sort. This is known as a point spread function. And in point spread function, we also see an effective blur, which is measured in diopters. In this case, it is 0.41. I don't want to get into the details of this. I'm just making you aware of the terms in all of this. Coming to modulation transfer function, like I mentioned before, it just quantifies the amount of aberrations. It does not tell us which aberrations amounts for how much, like what is the contribution of each higher order aberration in that total, but we get a rough idea as to how much it is aberrated from an ideal plane. An important point to note here is that when the object has a low spatial frequency, our brain can see it very well with a very high contrast. And as we start increasing the spatial frequencies, the contrast perceived by our brain is lesser and lesser. That is the measurement that we use to measure the modulation transfer function, which essentially means that how much of the contrast of the object is transferred to the contrast of the image. Here we see that the object, if it has 100% contrast, if it is of low spatial frequency, we can see it very well. As we go towards the high spatial frequencies, the object contrast still remains 100%, but the image contrast drops drastically. That is what we mean by modulation transfer function. So a modulation transfer function of 1 is perfect, as in 100% of the object contrast is transferred to the image, whereas 0 is imperfection. So what effect does having low contrast sensitivity or low modulation transfer function have on day-to-day basis? People face problems in night driving. People have problems pouring coffee in a dark mug, especially if it is a dark coffee, because a dark coffee against the background of a dark mug is difficult to judge. People have difficulty in walking down steps, difficulty in focusing on small fonts, and also asthenopia on prolonged reading. So a few practical considerations when we study about wavefronts, why we need to study them, because wavefront aberrometry and the study of wavefronts explains the symptoms of the patient, which are glare, halos, and starburst. It can also help us decide whether we have to go for a normal femto LASIK, which is wavefront optimized, versus going for a topo guided LASIK, which is the Contura LASIK. It can also help us decide whether to implant a spherical versus an aspherical IOL in the patient, and also decide upon which patients are good or bad candidates for premium IOLs. I'm going to cover all of this in the next few slides. So an important aberration that we all need to consider is the spherical aberration. Spherical aberration is proportional to the Q value of the cornea. Q value is basically the measure of asphericity of the cornea. The spherical aberration is also inversely proportional to the radius of curvature or the K values of the cornea. So a normal human cornea has a slight positive spherical aberration of around 0.27 microns. Whereas the normal Q value or the asphericity factor of a normal human cornea is somewhere around 0.026. We should not confuse between these two. The spherical aberration of a normal human cornea is positive and it is 0.27 on average. And the Q value, which is the measure of asphericity of the human cornea, is negative and it is 0.26. If the surface is completely spherical, the Q value is 0. As the surface becomes prolate, that is steeper in the center and flatter in the periphery, the Q value goes towards -1. When the surface is flatter in the center and steeper in the periphery, the Q value goes towards +1. We call this surface an oblate surface. So the relationship between Q value and spherical aberration is that whenever the center is more curved, the central rays get focused in front. In such patients, the cornea is more prolate and they have negative spherical aberration. In surfaces which are oblate and less prolate, like normal human cornea, it is a less prolate surface. We have positive spherical aberrations. Like I mentioned before, the positive spherical aberration of a normal human cornea is plus 0.27. So a study conducted by Reed et al., they have measured the topography and the Q values of central and peripheral corneas on average young patients, and they have found out this trend across various diameters of the cornea from the center. So at 6 mm it is around minus 0.19, and at 10 mm it is around minus 0.36. So it starts becoming the surface of the normal human cornea starts becoming more and more prolate towards the periphery. In this example highlighted in the orange box here, I am showing the Q values of a patient who has undergone RK. Previously, they have undergone RK, and we can see the very, very high positive Q value here. It is 1.43, and the trend of being more prolate has still continued in RK patients, wherein it has tended towards negative in the periphery. So again, an oblate surface or a less prolate surface is going to have a P value or Q value more than 1, which is what we are seeing here in this post-RK patient. So a natural cornea has a positive spherical aberration of 0.28, which is positive, and a negative asphericity of minus 0.26. So at a certain Q value of minus 0.53, the patient's cornea is said to have zero spherical aberrations. The normal cornea, it is slightly positive, has a slightly positive spherical aberration, which is plus 0.28, and it remains constant throughout life. The natural human lens has a negative spherical aberration of around minus 20 microns. So the total in total, eye has a slightly positive spherical aberration of plus 0.10 microns. However, when the lens becomes cataractous, this minus 0.20 starts becoming positive. So the overall spherical aberration of a cataractous eye becomes very highly positive, which is why the patient starts seeing glares and halos and starbursts. Here we can see
So,
in a,
can you
yes,
can you
sir.
can you stop here for a moment? I wanted to just ask you that, just like you showed that the negative spherical aberration, as the Q value approaches minus 0.58, the spherical aberration becomes almost zero. Huh? So, in the
Yes, sir.
same sense, when we are talking about IOLs, then what
Yes,
happens?
sir.
Like with, they call about like aberration free lenses. For example, Acris of IQ has a negative spherical Q value of about minus 0.27 or something. Technis
Yes,
also,
sir.
and then
Yes,
the
sir.
natural lenses, like for example, the spherical lenses, like the Sensor one, will have a
Yes.
positive spherical aberration. Okay,
Yes,
and
sir.
then they make the
Yes, sir.
Bausch and Lomb makes the aberration free lenses, which have no
Yes,
zero
sir.
aberration. Okay, so what will the zero aberration lens have as far as spherical aberration is concerned, and as well as the QLQ value is concerned? Will you be
Sir,
covering that in your talk, or do you?
yes, sir. Yes, sir. Yes, sir. Aberration, negative SAIOLs, positive SAIOLs, and zero SAIOLs. I'm covering that, sir.
Okay, okay.
Yes, sir. So, a post-hyperopic ablation patient has a more prolate cornea, which is steeper in the center and flatter in the periphery. Hence, it has a more negative spherical aberration. So, post-hyperopic LASIK patients have a more negative spherical aberration. Post myopic ablation, we have a oblate cornea, which is flatter in the center and steeper in the periphery. Hence, they have a positive spherical aberration. So, coming to the relationship of spherical aberration and depth of focus. So, let us consider that this eye is an emmetropic eye and it has no accommodation. So, it is not going to insert bias into our depth of focus discussion. This is the object that we have given to the patient, and this is the image that is formed onto the eye at the focal point on the fovea. And since it's an emmetropic eye, the image on the retina is sharp, and the image perceived by the brain is also sharp. In this patient, there is no spherical aberration, and the image has been formed only on the fovea. So, if we were to shift the object, the image is also going to shift and it is going to get blurred, and the image perceived by the brain is also going to be blurred. In contrast to that, if we add a spherical aberration into this mix, if a patient has spherical aberration which affords them a depth of focus, even if we slightly move the object, the image formed onto the retina within this limit is still going to be relatively focused, but due to neural adaptation, the image that is perceived by the brain is still going to be sharp. If we were to go beyond the threshold of this spherical aberration, the image formed on the retina is of course going to be blurred, but the image perceived by the brain is also going to be blurred. So if we were to induce a very high spherical aberration, the image formed, it is going to give us a great depth of focus, but the image formed on the retina itself in the first place is going to be very blurred, and hence we have to differentiate as spherical aberration between being a non-toxic spherical aberration and a toxic spherical aberration, or an acceptable value of spherical aberration versus an unacceptable value of spherical aberration. So this graph is showing a lot of things. I'll slowly take you through it. Here we can see a graph of the Q value of a normal eye is somewhere around 0.026, and we have correspondingly non-toxic spherical aberrations. Like I mentioned before, if the Q value is minus 0.53, we will have no spherical aberrations. If the person has no spherical aberrations, the person is going to have fantastic contrast sensitivity. As the spherical aberrations are going to increase, the contrast sensitivity is going to decrease. But as we know that as the spherical aberration is going to increase, the depth of focus is also going to increase, but there is a limit to which we can tolerate the spherical aberration, and there is a fine balance between increasing the spherical aberration and having a good depth of focus. So I'll be discussing about how this is going to affect our decision making in using spherical versus aspheric IOLs. So in spherical IOLs, the peripheral light rays are defocused. So rays from the periphery are going to be focused at points which is different from the points of the central rays. Whereas in aspheric lenses, because of the certain curvature, graded curvature of the lens, we are going to find that the rays from the periphery and the rays from the center, all of them converge onto the same point. So how does that affect the image? This is the image that a patient with a spherical lens is going to see vis-a-vis the image that that a person with an aspheric lens is going to see. A person with a positive spherical aberration is going to be seeing a grid of this appearance, whereas a person with a negative spherical aberration is going to see a grid of this appearance. So what is the basis for aspheric IOLs? In spherical IOLs, the curvature of the lens is constant, that it is uniform throughout the diameter of the lens. Because the curvature is constant and the distance of the point from the center varies, we are going to have variable power through all the points. With this lens is easier to make, but it gives us worse optics. In an aspheric lens, to get constant power at all points on the lens, we are varying the curvature. So we are having a variable curvature of aspheric IOLs, and the curvature slightly reduces as we go towards the periphery. So aspheric IOLs are harder to make, but they have better optics. So currently what IOLs we have in the market are positive spherical aberration, that is the most conventional IOLs, negative spherical aberration IOLs, and zero spherical aberration IOLs. So these are the kinds of IOLs we have in the market. So again, in a lens with positive spherical aberration, the power of the IOL increases from center to the edge. In a zero aberration or an aberration free lens, the power is uniform from center to the edge. In a negative spherical aberration lens, the power decreases from center to the edge. So what are the commercially available lenses of each type? In spherical lenses, we have Alcon SA6080, Sensar AR40E, and CT Spheris. In the zero SA or the aberration free lenses, we have Acreos, Envista, and Softport AO. In the negative spherical aberration ones, we have Acrysof IQ, which has a Q value of minus 0.20, a Technis lens, which has a Q value of minus 0.27, Hoya. Clarion also has a minus 0.2 micron Q value. So how does this affect our choice of IOLs? In a young patient, as I mentioned before, the cornea has a slightly positive spherical aberration of plus 0.28. The lens has a slightly negative spherical aberration of minus 0.20. So the patient has no spherical aberrations at all, and his accommodation is also very good. In a presbyopic patient, the cornea still has the same plus 0.28 spherical aberration, but now because of the aged clear lens, due to the change in the lenses, natural human lens, the spherical aberration has tended towards zero and starts becoming slightly positive. So the patient is going to have mildly positive spherical aberration, and this mildly positive spherical aberration is still going to give him a good increased depth of field. When we consider this, that the patient also is having lesser accommodation due to presbyopia, this mild positive spherical aberration is going to help us overcome that lack of accommodation a little bit. In a cataractous eye, the cornea still has a positive spherical aberration. The cataractous lens has a very high positive spherical aberration, and this is what the patient is going to see. Also, the patient has no accommodation, And at this stage, the spherical aberration is in the toxic zone, so it becomes a problem for cataractus patients. In pseudophakic patients who have a negative spherical aberration IOL, the patient is still going to have no spherical aberration at the end of the day because it is going to balance out the positive spherical aberration of the cornea. If the IOL is well centered within the visual axis of point and and within 0.5 mm, so it means to say that even if you decenter the IOL by more than 0.5 mm, the patient is going to have worse vision with negative spherical aberration IOL, which I'm going to demonstrate in the next few slides. Contrast that with a pseudophakic eye with a zero spherical aberration IOL. The cornea has a positive spherical aberration. The zero SA IOL has a zero spherical aberration. This mild positive spherical aberration is going to give us mildly increased depth of field, which is going to help us get a bit of depth of focus. So in traditional IOLs, have most depth of field because of the positive spherical aberration, which adds on to the cornea's positive spherical aberration. However, it produces the worst image quality. In zero spherical aberration IOL, it gives decent depth of field and good image quality. The negative spherical aberration IOL is going to give us lesser depth of field, but is going to give us the best image quality. So the image quality at focal point of a traditional IOL is the worst. It is very blurred out. For a zero spherical aberration IOL, it is good, but the best one, the best image quality is brought about by the negative spherical aberration IOL. Similarly, the depth of field, conversely, is best with the positive spherical aberration IOL. With the zero spherical aberration IOL, it is decent, but the depth of field due to the IOL itself, due to the spherical aberration with a negative spherical aberration IOL, is the least. So when do we decide to use which IOL? Positive spherical aberration design is mostly never used except for some post-hyperopic LASIK patients. The negative spherical aberration design is used when we want the best image quality, but we have to sacrifice a bit of depth of field. And if we are able to give good centration of the IOL in visual axis, so if the patient has pseudo exfoliation or zonular dialysis or zonular dehiscence, or we have wit loss, or we anticipate that the IOL is not really well centered, then negative spherical aberration designs are not ideal. In aberration free design, we get good image quality and good depth of field, and the centration is not as critical. So in the real world results, we can see that with the traditional IOL versus an aspheric IOL, there is 25% reduction in the contrast sensitivity with a traditional positive spherical aberration IOL. So I'm going to show you a few images of what people actually see. In an aspheric IOL, this is the kind of clarity which the patient gets versus a traditional positive spherical aberration IOL. So what does pupil size have to do with aberrations? So with small pupils and good lighting, the aspheric IOL and spheric IOL perform similarly because small pupils block the peripheral rays. So here we can see with the effect of pupil size, a spherical lens and an aspheric lens, the images are similar. If the pupil were dilated, say at time of night driving or in low light conditions, the aspheric lens performs much better than a spherical lens. Coming to the effect of IOL decentration. So with decentered IOLs, the aspheric IOLs perform better than spherical IOLs. But as we noted, the negative spherical aberration IOLs are very sensitive to decentration. So comparing how both types of aspheric IOLs. Sir, the meeting is about to end. I'm sharing another link. We will join in that, sir.
Okay.
Sir, I've shared the link and I'll continue till this meeting goes on. So
Okay, okay.
how do we compare both the types of uh, aspheric IOLs? If the negative spherical aberration IOL and the zero spherical aberration IOL both are perfectly centered, we know that the negative SA IOL has a clearer image. But as it starts getting decentered, the negative spherical aberration IOL, the image quality reduces drastically when it is compared to the zero spherical aberration IOL. So in a prospective cataract patient with prior hyperopic LASIK, we use the traditional IOL with positive spherical aberration. In a patient who has not had any prior corneal refractive surgery but has a risk of IOL decentration, we go with an aspheric IOL with zero spherical aberration. If the IOL is not likely to decenter and image quality is critical to the patient, we use an aspheric IOL with negative spherical aberration. And in patients with prior myopic LASIK, we straight away go for an aspheric IOL with negative spherical aberration. Sir, I just have 3, 4 slides left of real world, our own examples.
Yeah, yes, you can start.
Yes,
Can we go back like 2 slides?
yes, sir. Yes, sir. This one, sir.
Yeah. Okay.
Shall I start with this slide, sir?
Yes, yes, yes.
Okay. So, how do we choose an IOL on the basis of spherical aberrations? So, in a patient with a prior hyperopic LASIK, we go with a positive spherical aberration IOL, that is the traditional IOLs. In a patient who has had no prior corneal refractive surgery but has a likelihood of IOL decentration, we choose an aspheric IOL with zero spherical aberrations, that is the aberration free lenses. If the IOL is not likely to decenter and image quality is critical to the patient, we can use aspheric IOLs with negative spherical aberrations. However, if depth of field is critical to the patient, we can use aberration free lenses. In a patient with myopic LASIK, we use an aspheric IOL with negative spherical aberrations. Yes. So in this example, recently we saw a patient who was a long time follow-up patient who had undergone CXL twice and is a known case of keratoconus. In that patient, we saw that the total RMS, the root mean square aberration, which measures the aberration, is around 14, which is very, very high. So to put it in perspective, if we see an aberration, if we see an RMS value of zero point 0.4, anything above 0.4, we consider it to be a highly aberrated cornea and we straight away go for a topo-guided treatment rather than a normal femtoLASIK. So this value is 14. The Z40, the Z40, which is the spherical aberration itself is 0.4. So and it is positive. So this patient has a high positive spherical aberration and high overall higher order aberrations. So in this patient, if we were to do a cataract surgery, we will use an aspheric negative spherical aberration IOL to counteract the very high positive spherical aberration of the eye. Also, this patient is a poor candidate for multifocal IOLs because the cornea is highly aberrated. So in this patient, if we were to uh, if you were to undergo any refractive procedure, it has to be a topo guided treatment because the RMS value is off the charts. So in another patient who had come to us for LASIK consultation, we have noted that the internal aberrations are minimal. The corneal aberrations are also minimal. It is important to note here on this eye trace handout is that we note that there is no defocus. So whatever as whatever aberrations on the Zernike polynomials and the aberrations that we are considering, this no defocus point means that we are not considering hyperopia or myopia as a factor in these aberrations. The only thing that we consider are astigmatism, trefoil, and coma, and spherical aberration. So in this patient, the total aberrations were minimal. The total higher order aberrations were less than 0.07. And in the eye trace also, like I mentioned before, three higher order aberrations are very important, which is coma, spherical aberration, and trefoil. So these three are mentioned separately in each handout of the eye trace. So in this patient, the patient has low higher order aberrations. We can go for a traditional wavefront optimized LASIK or an FCAT, which is Q value optimized LASIK. And the patient, if we were, if say this scan was for a patient who was to undergo cataract surgery, this patient is a good candidate for multifocal IOLs. The pentacam of that same patient, the Zernike triangle, and the Zernike RMS was also less. The spherical aberrations are also low. So the patient is suitable for wavefront optimized LASIK. This is an interesting case. In this, one patient had come to us for LASIK consultation. On eye trace, we can see that the internal astigmatism is very high. The ones marked in red are significantly high. The ones marked in yellow are moderately raised. So anyway, the internal aberrations are very high. The corneal aberrations as well are significant, but we can see here that the internal aberrations are compensating for the corneal aberrations. So if the patient has to go for a refractive surgery, laser vision correction due to the high corneal higher order aberrations, first thing is this patient will undergo a topo guided treatment. Second point to note here is that lenticular higher order aberrations are compensating for the corneal higher order aberrations. So if this was a scan of a patient who were to undergo cataract surgery, the patient is going to be a poor candidate for premium IOLs, because once we remove the natural human lens, the compensatory values of the internal aberrations are going to go away, and the corneal aberrations are still going to stay, which are very highly significant, and they are not going to get compensated. So this patient is going to be a poor candidate for premium IOLs. So that was my class, sir.
Pranav, can we let's go back to the last slide. Okay.
This one?
So
Yes, sir.
I wanted, yeah, this one. So here I wanted to, I think what you discussed was nice. And only thing is that, so if you're going to, let's assume that this patient is going for a refractive surgery. You said that this patient should go for a topo guided, right?
Yes, sir. Yes, sir.
Now the thing is that, if you notice, the main aberrations on the cornea are basically the astigmatism. The others are not going off the charts, as you said, like the coma, and those are just in the yellow, right?
Yes,
Trefoil
sir.
is not even in yellow, and right. And frankly, those which are in the yellow are getting compensated by those on the internal aberrations, right?
Yes, sir.
To some extent, right?
Yes,
Now,
sir.
if you were to do a topo guided treatment and you were to treat all the corneal aberrations, first thing is those things which are getting compensated will get decompensated. Okay.
Yes, sir.
And number two, for doing astigmatic correction, which means the third and the fifth order of aberration, I mean the number three and number five, which is on the cornea, you don't need topo guided. You can correct astigmatism just by a wavefront optimized or an FCAT kind of a thing,
Okay, sir.
right? It's only for the higher order aberrations that you are going to need the topo guided treatment, isn't it?
Yes, sir. And also, sir, the astigmatism is regular astigmatism. The axis is 90 and 180.
Exactly. Exactly. So you could actually just go for uh, like a wavefront optimized correction for the astigmatism and whatever is the refractive error, and leave behind those aberrations which are actually kind of neutralizing the internal aberrations, which you can't do anything about right now if you're doing a corneal based surgery,
Yes, sir.
right? So,
Yes, sir.
so what we could do is that we could actually do an ablation which is cyclotorsion controlled, like even wavefront optimized can be cyclotorsion controlled for the high astigmatism, and yet get a good outcome. You don't necessarily have to go for topo guided here, but then if you were going to go for topo guided, if you understand what Forsides does, basically your corneal astigmatism is very high and is partly being compensated by the internal astigmatism, which is in the opposite. It's in the red. So
Yes, sir.
your total astigmatism actually would be a little less, the manifest astigmatism. So when you treat this patient, you may not want to correct the full astigmatism which is there on the cornea. For example, when we do Forsides calculation for contour treatments, you will notice that, suppose the corneal astigmatism is -4 and the manifest is -3. Okay, so what Forsides will do is it will not ask you to treat the -4. It will convert that into a 3.25 or a 3.5, something like that. Dr. Ruchika, would you like to say anything here?
Yes, sir, I agree with, I mean, what you're saying is right.
So these are just thoughts because these are open to discussion. I'm just thinking that, in that patient, this might just, if you're doing laser correction, now if you're doing a cataract surgery, frankly, again, Pranav, what I might think is when we are going to do a cataract surgery, we are going to remove the internal aberrations completely, right? So they won't matter at all. They'll be gone mostly, right?
Yes, sir.
Yes.
And yet we will be left with primarily astigmatism on the cornea.
Yes, sir.
So Torek would do very well
So
in
if
this.
we were to treat the astigmatism, exactly. So if we were to do a toric IOL, and maybe we could still go for a premium IOL here because astigmatism would be corrected by the toric IOL
By
anyway.
Torek. Yeah.
So if
Yes,
we
sir.
had to use a premium IOL, I'm just wondering whether those amount of aberrations which we are seeing on the cornea, because the internals will be gone, and on the cornea we have some aberrations which are not again phenomenally high. So do you
The
think this patient can still be a candidate for a premium IOL? What about his angle kappa and angle alpha and stuff
I
where
think
is that?
depending on pupil size, even a multifocal toric could could be put in this patient. But it all would depend on the size
That's
of
what I
the
was
pupil.
thinking, but that's what I'm kind of trying to think whether that is a good idea, whether, because this is what we will learn from this eye trace. So, Pranav, what do you think? Do you think that we can do a premium multifocal toric IOL in case we are removing all the internal aberrations and we are correcting astigmatism with a toric IOL and leaving behind the amount of trefoil and coma which is evident here? Are
Mm,
we still within the tolerance zone for doing a toric
sir,
IOL, I mean a multifocal IOL?
I would still want to draw your attention to the tracy refractions at different sizes of pupil. At 2 it is
Hmm.
this, and at 4.6 it is vastly different. So I think that considering that
No, no,
also
no,
the
no. At
patient
4M,
might
it
not.
is not 4 mm. 4 mm, it is not vastly different. I mean, if you look at the overall tracy refraction, it is similar to the one at 4. But yes, if you look at 2 and 3 mm, but that would again, at 2 or 3 mm, basically what you're doing is you're removing a lot of the aberrations which are from the periphery. Now, we don't know whether it is removing the lenticular aberrations or the corneal aberrations.
Yes, sir.
And the corneal astigmatism basically will get corrected completely by the toric IOL anyway. And the internal aberrations you are removing.
Yes, sir. Then it's a good case. I mean, we can make a case that the patient can be considered for a premium IOL.
So he may
And by
not be a great case for a premium IOL, but he can still be a consideration for a premium IOL if we have to.
yes, sir.
But if anybody differs, I'm open to discussion. Like if anybody wants, because maybe I'm not, you know, I'm missing something. So, Dr. Rujika, what do you think? Like, because you are dealing with these aberrations every day as well.
So with, I mean, if we are considering a premium IOL for this patient, again, we have to look at the angle kappa and alpha. Alpha is that it doesn't show up in this scan.
No, it is there. Angle alpha is there, which is important from premium, not angle kappa. So angle alpha D
Angle
is
alpha is within
0.224.
nominal maximum.
Yeah, okay. So I think, yes, I mean, the corneal astigmatism is way more than the lenticular in this case. So definitely, I guess a toric IOL would work fine in this patient.
Right.
Yeah.
Any other questions from the whole presentation? If anybody wants to discuss anything, it will be nice because we can. Pranav, is your presentation over? I mean, otherwise, is it over? It's only the discussion part remaining now.
Yes, sir. Yes, sir. It was mostly pictures, sir. I did not want to do a
Right.
lot of theory in the
No,
first
it was
class
a very
itself.
good presentation. I'm very happy with your presentation. You did a very good job because you made it simple for everybody to understand. So if anybody wants any questions or anything to discuss or any thoughts or any doubts or any comments or any suggestions, it'll be great.
I think the use of EKR map on the pentacam should be stressed more than the Zernike analysis uh, when it comes to implanting the toric IOLs. Uh,
Yeah,
because
I mean, in eyes which are post-refractive surgery, the EKR map will come into play, definitely. But today's class was basically on aberrations and understanding the aberrations. So that's why we were limiting
yeah,
ourselves to just the aberrations today. But
yeah.
yes, if we go into that area of trying to do toric IOL and refractive post-refractive surgery or otherwise abnormal corneas, then the EKR map would be useful. That we can to cover up another day, I think. So, but
Also, sir,
overall, I think,
I had one doubt. I mean, it is not related to this
yeah.
discussion as much, but sir, you make your incisions in the cataract surgery at 135 degrees in both the eyes. So, do you
Uh,
think, I mean, why would you still make a superior or a superonasal or a superotemporal incision when most of the surgeons are pushing towards a temporal incision? Is it a personal preference or is it because you have found the results to be better with those incisions?
no, so there is no personal preference as such. It is only because, I at one point I was doing temporal incisions, and then for me to move around temporal and change like from the left to the right and the right to the left was becoming sometimes logistically an irritating thing. And so I then decided that, I will just do a supratemporal or a supranasal, which I'm comfortable with doing. It does not change anything about my outcomes. And frankly, purely temporal incisions sometimes I feel are not protected because the supratemporal and supranasal incisions, being clear corneal, they are better protected by the supraorbital rim. So if a patient was to get any trauma from the temporal incision, I would be more uncomfortable leaving an unprotected, temporal clear corneal incision there, which is exposed completely to any kind of, pressure or trauma. So that's one reason. And also because for the SIA point of view, initially they used to stress that temporal incisions are much better, SIA will be much less, but now we understand that SIA is not dependent on, you know, uh, many factors which we used to think they are. So I'm using an SIA of only zero point 0.1 at 135 also. So in that sense, it becomes much easier for me. And also then for the two eyes, my toric calculation remains the same. Otherwise, what they'll have to do is they'll have to do my toric calculation in different for the both eyes. They will have to do different calculations. Right now, they don't have to change anything. So that's the third thing. But otherwise, yes, it's a personal preference also. I think no particular reason that I'm doing this. It's just more comfortable for me to just sit superiorly and finish off the cases. There are occasional patients where I see very deep set eyes or eyes which have very poor access superiorly. Then I will just move for the left eye. For the right eye, I can do clear corneal temporal even sitting at 12 o'clock. So I
Okay.
don't have to move my position to the temporal thing. For the left eye, I move sometimes.
Yes, sir.
Anybody else has any suggestions or thoughts? So anyway, I think it was a very good class. we learned a lot. I learned a lot. And, if anybody has any thoughts, we can always discuss it on our group, and we can then you know, have another better understanding of some other aspects as well later in a later class. So I
Yes,
think
sir.
we can call it off in case there are no other questions. So thank you so much, Pranav, and thank you everybody for joining. Until
Thank
we
you,
meet
sir.
next time. Okay. Good night, everybody.
Good night, sir. Thank you.
Thanks, Pranav.
Thank you, ma'am. Thank you, Rohan, sir. Thank you, Mrinal, sir.